My name is Jeffrey Borer. I'm at the State University of New York Downstate Medical Center in New York City. I spoke about the need for reassessment of anticoagulation strategies in patients with heart valve disease. The primary reason that this has become of interest again is the recent development of new oral anticoagulant drugs that could, in theory, allow acceptably safe anticoagulation without the difficulties associated with warfarin, the standard anticoagulant. There are three reasons why anticoagulation is important to consider in people with heart valve disease. Number one, heart valve diseases are intrinsically thrombogenic. Second, heart valve disease is predisposed to atrial fibrillation, and atrial fibrillation is inherently thrombogenic. And third, the treatment for severe heart valve disease is replacement or repair, replacement with a bioprosthesis that is, or any prosthesis that is inherently thrombogenic, and even repair with materials that are inherently thrombogenic. So there are good reasons to be thinking about when we should anticoagulate and how we should anticoagulate in people with heart valve disease. The problem with patients who have unoperated heart valve disease without atrial fibrillation is that we don't know the magnitude of the thrombogenic risk. That's never been defined. We can define this, though, for some subsets of patients, particularly those with anti-cardiolipin antibody excess. This has been known for a number of years, but hasn't really been included in guidelines and discussions. In our studies, we found that in a consecutive series of 87 patients with regurgitant valve disease of the aortic or mitral, approximately a third had abnormal, that is more than 3 standard deviations higher than the average normal value anti-cardiolipin antibody titers, and 1/3 of those patients had strokes. So we can at least identify in that subgroup of patients high risk in a situation where anticoagulation probably would be beneficial, particularly if the difficulties associated with warfarin of over-anticoagulation and hemorrhage or under-anticoagulation and thrombosis were not so much of a problem. Same thing for atrial fibrillation in unoperated patients with valvular heart disease. We don't know the magnitude of the risk. We don't know the magnitude of the thrombotic risk. And in patients with unanticoagulated prosthetic valves, we do know the magnitude of the risk. It's approximately 10% per year. So these people always are anticoagulated. The problem, though, is that these people who are anticoagulated with valve prostheses still have a 2% per year risk of thrombosis and thromboembolism. So what we do isn't good enough, even with warfarin plus aspirin. The use of new oral anticoagulant agents presents a potential solution to the problem. But so far, we can't say that that solution is real, because in the one trial that's been done, called the REALIGN trial, it was shown with dabigatran, one of the new oral anticoagulant agents, that in fact the thrombosis risk was substantially higher than with warfarin, substantially higher. So that this is not a solution. More research needs to be done to find out what the abnormal interaction is between prosthetic material and dabigatran and perhaps other new oral anticoagulants to determine the appropriate doses or the appropriate modifications of the drugs so that they could be of benefit in patients with prostheses in place. In terms of atrial fibrillation in patients with valvular heart disease, no studies are available. And in terms of studies of patients with valvular heart disease without anticoagulants, without prostheses, and without atrial fibrillation, there are no data. So we need a great deal more research. This is an important problem. Thromboembolism in patients with valvular heart disease is real. It occurs. It causes major morbid and even lethal adverse events. And we need to be thinking about and studying these problems further and developing strategies for appropriate anticoagulation.